Good morning, everyone, and welcome to the 64th Annual Meeting, the 8th World Congress on Exercise as Medicine, and the World Congress on Basic Science of Exercise and the Brain. We hope to see you all in Minneapolis 1 year from now at the 65th Annual Meeting. And don't forget that Minneapolis, just this month, was ranked #1 in the AFI, American Fitness Index. And Walt Thompson reminded me that today at 11:45 a.m., to celebrate the 10th anniversary of the American Fitness Index, Governor Hickenlooper of Colorado will be at CC 104, Convention Center Room 104, 11:45. As you entered the hall today, you noticed that there were distinguished gentlemen and distinguished ladies handing out bookmarks. When a long-term member of the American College of Sports Medicine reaches retirement, that person may apply for and be awarded the designation of either member emeritus or fellow emeritus. Something for you to think about. A continuing interest in the college is an excellent indication of continued dedication to the regional and national sports medicine activities. Serving today as hosts at the entrance of the hall were emeriti who are participating in this year's annual meeting, several of them being past presidents. And we thank them for their contribution today. I'd like to take this opportunity to recognize another group of elite members of the college. In 2011, the ACSM Board of Trustees approved the category of legacy members in an effort to honor the unique contributions of senior individuals who have contributed significantly to ACSM in the past. This group consists of the living past presidents, past honor award recipients, past Wolf lecturers, 25 years after the end of that event. A complete listing is on page 5 of the conference and exhibit guide, but we are honored to have 5 of those legacy members here today, and there are 29 total. I'd like to ask David Lamb, Neil Oldridge, Peter Raven, Brian Sharkey, and Jim Skinner to stand, please. Congratulations and thanks for all that you've done for ACSM. I can't imagine where I'll be in 25 years. The D. Bruce Dill Historical Lecture, as you all know, is named after a pioneering scientist and past president of ACSM. I know him basically for his essential studies in the desert of the Southwest and for his work at the Harvard Fatigue Laboratory. He made fundamental contributions to our understanding of the human physiological and metabolic responses to exercise. So this keynote lecture deals with the history of sports medicine and exercise scientist. And as the most recent past president of ACSM, I have the honor of introducing our D.B. Dill Historical Lecturer, Dr. Barry A. Franklin, who's a fellow of ACSM. Dr. Franklin serves as Director of Preventive Cardiology and Cardiac Rehabilitation at William Beaumont Hospital in Royal Oak, Michigan, and holds faculty appointments as a Professor of Physiology and Professor of Internal Medicine at both Wayne State and at Oakland University William Beaumont School of Medicine. His research over the past 4 decades has combined exercise physiology, cardiac rehabilitation, preventive cardiology, and lifestyle medicine. He's not only a past president of ACSM, he is a past president of AACV-PR. He's held multiple leadership positions also in the American Heart Association. His professional accomplishments have been recognized through a number of honors and awards from AHA, AACV-PR, and also William Beaumont Hospital, and he's received the citation and honor awards of this organization. Currently, Dr. Franklin serves on editorial boards of 15 scientific and clinical journals. He has written or edited 483 papers, 85 book chapters, and 26 books, and has given over 1,000 invited presentations. Thus, it's appropriate that the title of his presentation today, because of his expertise and because of the topic of this lecture, the D.B. Dill lecture, the title of the presentation today is Extreme Exercise and Cardiovascular Health, Changing Paradigms and Perceptions. Dr. Franklin, please come to the podium.
Good morning. Dr. Armstrong, thank you so much for your kind introduction, as well as my thanks and appreciation to President-elect Thompson and the program committee for the honor and privilege to deliver this year's Dill Lecture. Dr. B.L. Bennett described David Bruce Dill as a man of many seasons and environments, committed to life, heat, and altitude. In 1927, he became one of the founding faculty of the Harvard Fatigue Laboratory in the School of Public Health, which he was associated with until 1947. From 1950 to 1951, Dill served as president of the American Physiological Society. And as already alluded to, he served as the 4th president of ACSM in the year 2000. He was the first with a PhD. The first 3 presidents were MDs and founders. Throughout his career, Dill made contributions in the fields of exercise science and environmental physiology. In the process, he led expeditions to high altitude, tropical and desert environments to study the effects of extreme environmental conditions. He continued his research in the Nevada desert to the age of 95. As a preface to this lecture, it's important for you to recognize that in recent years we've had an explosion of participants involved in high-volume intensity endurance training. In fact, as we look in 2015, there were approximately 2.5 million marathon participants in the U.S. as compared with 25,000 in 1976. There's been a similar exponential growth in other endurance events with, for example, 4.2 million triathlon competitors in the U.S. last year, a doubling since 2011. But I view this in many respects as a population paradox. We've got more people who are inactive than ever before, but we've got an increasing subset of the population who are involved in high-intensity, high-volume endurance training. I've addressed the question today in my lecture, the Dill Lecture, is more exercise always better? And if you want the take-home message, probably from a performance, that may be the case, but not necessarily so when it comes to health and survival. This morning, I'm going to cover 8 topical areas. The first one being cardiorespiratory fitness, walking pace, and mortality, and cardioprotective mechanisms associated with physical activity and increased aerobic fitness. Sharma, in this provocative clinical update, highlighted the benefits of regular physical activity with specific reference to cardiovascular adaptations. He also emphasized, however, that over the past 2 decades, emerging data indicate that long-term vigorous exercise may, ironically, be associated with adverse electrical and structural remodeling, resulting in arrhythmias, myocardial fibrosis, and possibly an exacerbation of coronary artery disease. I want to first start off by talking about physical activity, fitness, and its impact on cardiovascular and all-cause mortality. In this landmark report of over 6,000 men by Dr. John Myers and colleagues, who were exercise tested and followed over a 13-year period. Low exercise capacity, which they defined as less than or equal to 5 METs, which essentially implies for those clinically involved that that individual can't complete stage 1 of the Bruce treadmill protocol, 1.7 miles an hour, 10% grade. That fitness level was associated with an extremely high mortality rate in Dr. Meyer's early study. In fact, it was associated with the highest mortality rate and even more strongly than that of established risk markers, including smoking, hypertension, diabetes, previous myocardial infarction, and even congestive heart failure. You say to me, Barry, give me the information on cardiorespiratory fitness and all-cause mortality. I've summarized a lot of the key studies in this one slide. The take-home message is most studies indicate an asymptotic gain when we talk about fitness of about 9 to 10 METs, which is equivalent to stage 3 of the Bruce treadmill protocol. These are approximate cut points that have now been substantiated by others, and I've shown those in small print at the bottom of this slide, beyond which further improvements in fitness were associated with little or no additional survival benefit. So my first take-home message is this: men and women who are unable to achieve 5 METs during treadmill testing at high risk for cardiovascular and all-cause mortality. In contrast, the risk of cardiovascular death is very low in those with fitness levels higher than 10 METs. And in fact, a recent report from the Henry Ford database suggested even greater benefits in terms of survival for those who are able to achieve 14 METs. When we talk about the magic of 10 METs, I was taken back by this report, once again from the Cooper Clinic, study of 710 asymptomatic men from the Aerobics Center longitudinal study, whose fitness was classified as less than 10 METs or greater than or equal to 10 METs, but who also had coronary artery calcium scores in excess of 100. During 3.5-year follow-up, the age-adjusted hazard ratio, as you see in this slide, was 0.26 in men whose fitness levels were greater than or equal to 10 METs, compared with men less than 10 METs. Their conclusion: in asymptomatic men with subclinical coronary disease, that is, coronary calcium scores greater than 100 and exercise capacity greater than or equal to 10 METs, identifies patients at the lowest risk for manifest cardiovascular disease. This report also got my attention. Once again, data from the Cooper Clinic longitudinal study of over 16,500 participants, where they looked at risk factors and fitness. The investigators constructed a clinically useful, sex-specific 30-year risk estimator website, which is shown in this slide. But the take-home message for me as a clinician was this: regardless of the risk factor profile, that is, regardless of whether the risk factors are good, poor, or superior, overall, low-fit men and women have approximately twice the 30-year risk of cardiovascular mortality. What also interested me about this particular study is if you look at the men and women who had virtually no risk factors in their 40s and were followed over the next 30 years, basically you're looking at this cohort and this cohort. Those individuals, regardless of fitness level, had the likelihood of cardiovascular mortality of less than 10% for men and less than 8% for women. I think it's also important to recognize simple walking speed. We know that walking distance, walk performance tests, weekly walking distance, but simply new studies suggest that simply looking at the patient's walking speed on a day-to-day basis provides you with valuable prognostic information. So I now tell our residents and fellows, simply look at the patient when they walk in or out of your office, because that could be the most significant vital sign that you'll see that day. A tortoise-like pace, based on these two studies, that is less than 2 miles an hour, may provide the most telling vital sign of your physical exam that day. What are the benefits of exercise training? Typically, we talk about anti-atherosclerotic, anti-ischemic, anti-arrhythmic, and anti-thrombotic, but if you ask me to pinpoint what I believe is probably the single most important cardiovascular adaptations, I'd put my money on the anti-arrhythmic. That is increased vagal tone, decreased adrenergic activity, and increased heart rate variability. In fact, a recent study from the European Heart Journal showed for heart patients taking beta blockers, for each 10-beat lowering of the resting heart rate, there was a 30% reduction in cardiovascular mortality. Lower heart rate, better survival, and lower heart rate is a key index that we see with exercise training. Topic number 2, exercise-related cardiovascular events, risk of marathon running, and impact of regular exercise on exercise risk. What do you need to know here? I remember turning on the television a few years ago and they said exercise can kill you, details at 11. I normally go to bed at 10, but I stayed up till 11 o'clock to see what the newscasters were going to say. And they had a big program on why exercise is in fact risky. Exercise is good for you. Yet they highlighted a runner who died after the London Marathon, triathlete who died of a heart attack, endurance exercise kills. It went on and on and on, almost nauseating. I must admit, however, that when I saw this, shortly thereafter, we had an unusual experience in Detroit, my home city, where we set a world record. 2009 Free Press Marathon, we had 3 people drop dead within 15 minutes of each other, age range 26 to 65. Got my attention, got worldwide attention. And as a result of tragedies like these, the American Heart Association said we need to put together a statement on exercise and acute cardiovascular risk. What are the absolute, what are the relative risks? And I was indeed privileged to work with Paul Thompson and an esteemed group to clarify this essentially a decade ago. In this paper, we highlighted the fact that it is true that acute exercise leads to a cascade of physiologic and clinical responses, including increased catecholamines, sodium-potassium imbalance, which can lead to myocardial irritability, ultimately triggering ventricular ectopic activity. Big increases in sympathetic activity, vagal stimulation decreases, as a result, a big rise in the rate pressure product, a key index of myocardial oxygen demand, not a problem, unless you got clogged coronary arteries, which exacerbates ischemia, which can be highly arrhythmogenic. We also recognized that immediate post-exercise, people may suddenly stop myocardial demands, heart rate may still be high, decreasing blood pressure, decreasing perfusion, exacerbating ischemia. From a real world standpoint, that's what it looks like. I've seen ECGs like this being in a clinical setting now for 40 years. The ones that concern me most is when I see ventricular tachycardia and it's preceded by adverse signs or symptoms suggesting myocardial ischemia, then you know you're headed for more dangerous cardiac arrhythmias. Good friend and esteemed colleague, Dr. Paul Thompson, highlighted more than a decade, 2 decades ago, virtually, in the Archives of Internal Medicine, the fact that exercise may provoke plaque rupture by 4 mechanisms. One of the key mechanisms, he said, was via an increase in heart rate and blood pressure, shear forces, which can provoke vulnerable coronary plaque, leading to coronary thrombosis. The ECG you see here was from a stress test in our lab at Beaumont Hospital that unfortunately went bad. I remember showing this to a student intern, and I asked what this was, and he said, early repolarization? I said, no. How about right bundle branch block? I said, no. That's acute myocardial infarction. It's ST segment elevation. This patient went immediately to the cardiac catheterization lab, and a heart attack was literally halted in the cath lab with no Q waves, no residual damage. He was at the right place at the right time. This paper really got worldwide attention because it highlighted something that we need to know as exercise professionals. Highlighted the fact that overall, in this meta-analysis, there was a 5-fold increased risk of sudden cardiac death, a 4-fold increased risk of acute myocardial infarction during vigorous intensity physical activity, which they defined as greater than 6 METs. However, these associations were markedly attenuated among persons with high levels of habitual activity. For example, marathon runners. So the increase is not typically 4 or 5-fold, but much lower in highly trained athletes. As a result, this paper got my attention by Kim and colleagues, published in the New England Journal of Medicine. What impressed me about this paper, it was a 10-year study. It involved 10.9 million registered marathon runners, 59 cases of cardiac arrest, mean age 42. 51 of the 59 were men, average age 42. Essentially, what this indicates then is that what we had in Detroit, 3 deaths within 15 minutes, was truly an anomaly. And that on average, these data suggest approximately 4 fatalities per year. The conclusion, marathoners are low risk for acute coronary events, and very importantly, the final mile. That is, the last 5% of the whole marathon distance accounts for about 50% of all sudden cardiac deaths. In this study, the most frequent clinical and autopsy findings were hypertrophic cardiomyopathy and atherosclerotic cardiovascular disease, respectively. Topic number 3, 3 out of the 8. Marathon running and immunity to coronary heart disease. Classic case report was done years ago on the marathon runner Clarence DeMar. DeMar was a championship marathoner who continued running for 49 years. On 15 occasions, he finished among the top 10 finishers. DeMar died of cancer, approximately age 70. When they examined his heart, and that was done by Kearns and the late Paul Dudley White, they found nothing to suggest that long-term exercise caused any harm. I think the most remarkable findings, the most striking finding, was that the coronary arteries were estimated 2 to 3 times normal diameter, although we can't say perhaps DeMar didn't succeed as a marathon runner because he was born with unusually large coronary arteries. That's a possibility. Also, they noted atherosclerosis was present, but for the vast majority of arteries, they were relatively mild in degree, estimated to be reduced at 30% or so in most cases, most sites. This description and others on physically active populations, including the Maasai warriors and Tarahumara Indians, were used by a guy by the name of Thomas Bassler to support the contention that athletes who are so fit and capable of running a marathon, 26.2 miles, he hypothesized are virtually immune to coronary atherosclerosis. That was 1975. The next year, this report came out that got worldwide attention. Green and colleagues, Annals of Internal Medicine, Fatal Myocardial Infarction in Marathon Running. In this case, they document a 44-year-old trained marathon runner who collapsed after completing a little over 24 miles, getting back to that high-risk zone of the Boston Marathon. He was resuscitated from ventricular fibrillation. Death occurred after 50 days of coma. Extensive transmural anterior MI was documented on the ECG and proved at autopsy. We believe, they went on to say, this report is the first documentation of acute MI in a trained athlete while participating in a marathon. Good friend and esteemed colleague, a couple years later, Dr. Tim Notes and Lionel Opie published landmark case reports, 4 case reports of autopsy-proved coronary atherosclerosis in marathon runners. But the report that got my attention was this one, published by Handler and colleagues, Symptomatic Coronary Disease in a Marathon Runner. And I've often used this in presentations. This was a highly trained marathon runner who began complaining of chest discomfort during his last marathon, went to his physician. Physician initially poo-pooed it, said, you just ran a marathon a few weeks ago, there's probably nothing going on, maybe it's musculoskeletal. This individual also had a remarkable low-risk coronary risk factor profile, no major risk factors. They went ahead and did an exercise stress test, however, and the results of the stress test are shown in this slide, in which that individual marathon runner once again complained of chest discomfort, and you can see some significant ST segment depression in the lateral precordial leads. They went ahead and did a cardiac catheterization, which is shown in this next slide, revealing a 99% stenosis of the proximal LAD. They concluded this report in JAMA that this patient represents unequivocal evidence that long-distance marathon running and an unremarkable risk factor profile are not necessarily protective against the progression of coronary atherosclerosis. More recently, acute coronary thrombosis in Boston Marathon runners. There's one or two people sitting in this audience who actually put this case report together. We described 3 male athletes in good condition without diagnosed coronary disease who presented with acute coronary thrombosis immediately after completing the 2011 Boston Marathon. And here what you see on the left-hand side, acute coronary thrombosis with the arrows before, images only on the left, and after, images on the right, percutaneous coronary revascularization. In fact, what you see in the top right-hand corner is an insert, fragments of a white thrombus that was actually aspirated from the left anterior descending artery of this particular runner. Topic number 4, exercise. Is it possible to get too much of a good thing? LaGersh, in this very provocative paper, which got my attention and lots of people's attention, highlighted the fact that most of the data that we have is really on individuals who are participating in mild to vigorous physical activity, but exercise at the extremes he hypothesized may have a typical dose-response curve, analogous to the exercise is medicine analogy, with a plateau or even toxicity at more extreme levels. I now have a personal collection of reports that are rather alarming, at least 70 reports in my folder, highlighting adverse effects noted, physiologic, clinical, biochemical, echocardiographic findings after high-intensity, high-volume training, at least transient adverse effects. LaGersh published this report that got worldwide attention, abnormalities following an ultra-endurance exercise, 27 athletes competing in a triathlon. What they showed is an increase in cardiac troponin, which we typically see in the setting of acute myocardial infarction, B-type natriuretic peptide, oftentimes an index of congestive heart failure. In the immediate post-race setting, echocardiographic studies simultaneously revealed evidence of both left and right ventricular dysfunction. This resolved after about 7 days. They concluded from these studies that cardiac injury patterns seen after intense exercise may in fact represent a potential for the generation of scar tissue and malignant cardiac arrhythmias. This is a study we did at William Beaumont Hospital. Justin Trevax now is one of our attending cardiologists. He was a fellow at the time. We published this in 2010, 1 year after there were 3 deaths in the Detroit Free Press Marathon, because he wanted to look at more sophisticated cardiovascular imaging, specifically cardiovascular myocardial resonance imaging, to look at these 25 runners, average age 35 to 40, average VO2 max 55 ml per kg per minute, before and after running the Free Press Marathon. Cardiovascular magnetic resonance imaging we used, and what we found is that marathon running caused dilatation of the right atrium, right ventricle, big right pressure overload, reduction of the right ventricular ejection fraction, which you see in the bottom half of this slide, and release of cardiac troponin I and B-type natriuretic peptide, but did not appear to result in any lasting injury to any chamber. More recently, Wilson looked at 12 veteran endurance athletes using these newer tissue characterization techniques, including delayed gadolinium enhancement and cardiovascular MRI, and described diverse patterns of myocardial fibrosis in 6 of the 12 highly trained endurance athletes. Topic number 5, 5 out of 8, physical activity, fitness, and atrial fibrillation, reverse J-curve pattern. What are some key studies here that got my attention? This schematic, I think, was very telling, published just a few months ago by Kim and Bagish in Current Atherosclerotic Reports, in which they highlighted the fact that light to moderate exercise is associated with a host of beneficial, healthy adaptations. But once we start getting to the point of extreme and excess, they were bothered, as were many people bothered, by a number of reports suggesting that we begin to lose the mortality benefit, or there's more likelihood of atrial fibrillation, or pathologic cardiovascular remodeling, or coronary atherosclerosis. This study got my attention. Published in the Mayo Clinic Proceedings by Williams and Thompson, it used the National Walkers and Runners Health Studies to examine the dose-response relationship between exercise, energy expenditure, and cardiovascular-related mortality in nearly 2,400 heart attack survivors over a 10-year follow-up period. They found that chronic running and walking in these heart attack survivors, the more they did, the better, up to a point. Beyond 5.4 to 7.2 med hours per day, that was the maximum reduction, that is 63%. Beyond that point, those who did more, much of the survival benefit was lost in what we refer to as a reverse J-shaped curve. So those really doing lots of exercise had a poorer prognosis. Some people said this was an anomaly. There's probably not another study that'll attest to this. They were wrong. This paper also, same year, published in Heart Online, reverse J-shaped association, leisure time physical activity with prognosis in over 1,000 patients with stable coronary disease followed over a 10-year follow-up period. They looked at cardiovascular and all-cause mortality. Look at these data. What they found, not surprisingly, was that the highest cardiovascular mortality and highest all-cause mortality were in those patients who rarely or never exercised. The lowest was, in fact, in those who exercised 2 to 4 days a week, right here. But interestingly enough, those who did high-intensity, vigorous daily workouts had about twice the mortality as those who did 2 to 4 times a week workouts. In this report, using the Aerobic Center Longitudinal Study Database, Lee et al. Examined the effects of leisure time running on all-cause and cardiovascular mortality. In 55,000 adults, 18 to 100 years of age, average age 44, approximately a quarter of these individuals were regular runners. During a mean follow-up of 15 years, they found that compared to the non-runners, runners had a 30 and 45% lower adjusted risk for all-cause and cardiovascular mortality, respectively, with a 3-year life expectancy benefit. What blew my mind is that when they divided the running dosage into quintiles, of lesser running to greater running, they found that those who ran less than 51 minutes a week, or less than 6 miles a week, or 1 to 2 times, or less than 506 med equivalents per minute, or even less than 6 miles an hour, those small running doses were sufficient to reduce the risk of mortality compared to not running. So if you look at these data, for the most part, with the exception of running speed, you'll find you get your biggest bang for your buck by just doing some running, as opposed to 40, 50, 60 miles a week, just doing less than 6 miles a week, or running 1 to 2 times, or less than 506 minutes per week, offered lots of benefits. In contrast, the optimal running speed here appeared to me to be between 7 and 7.5 miles per hour. This study also got my attention, the Copenhagen City Heart Study, in which they followed 1,100 healthy joggers and approximately 4,000 healthy non-joggers over a period of 12 years. What did they find? Findings suggested, once again, this U-shaped association between all-cause mortality and the dose of jogging calibrated and the frequency of jogging. Light and moderate joggers had lower mortality than sedentary non-joggers, not surprising to me. But once again, strenuous joggers had a mortality rate not statistically different from that of the sedentary group. A couple points that I think are worth noting in this slide that probably could have been better emphasized. In this study, the greatest number of deaths by far was in the sedentary non-jogger group over that 12-year period. Secondly, the dose of running that was most favorable for reducing mortality was jogging 1 to 2.4 hours per week with no more than 3 days of running per week at a slow to average pace of about 5 miles per hour. Another major limitation that I'm surprised was not highlighted in the news media was the fact that in contrast to the size of the sedentary, light, and moderate jogger cohorts, the number of strenuous joggers that they studied was only 40. And over that period, 2 of those 40 died, which had a profound impact on suggesting that strenuous exercise results in a poorer prognosis. So there were limitations with that study. In this report, Armstrong and colleagues, in a large prospective study of over 1.1 million women in the UK, 9-year follow-up, once again showed this U-shaped or J-shaped reverse relation, looking at the incidence of coronary disease, cerebrovascular disease, and venous thromboembolic disease. If you look here over the 9-year follow-up as compared with inactive women, those reporting moderate activity had lower risks of all 3 conditions, not surprising. However, women reporting strenuous physical activity had higher risks for coronary heart disease, cerebrovascular disease, and venous thromboembolic events than those reporting such activity 2 to 3 times per week. We also have increasing number of reports today, highlighted in this paper by James O'Keefe in the Mayo Clinic Proceedings, that extreme exercise is associated with an increased risk of atrial fibrillation up to 5-fold. What's the mechanism? Perhaps Pradell summed it up best when he suggested that maybe the inflammation and fibrosis associated with extreme exercise regimens, atrial and ventricular dilatation and hypertrophy, increase in vagal tone at rest, enhanced sympathetic tone during exercise may collectively account for the substrate that leads to the development of atrial fibrillation. Somewhat contradictory data were provided in this report by Kokonas, Fazelis, John Myers, and others, which examined the association between exercise capacity expressed as peak METs and the risk of developing atrial fibrillation in approximately 6,000 veterans over an 8-year follow-up period. As you see here, they had 4 fitness categories. Interestingly, the risk was 21% lower for each 1 MET increase in exercise capacity in this study. That is the risk of developing atrial fibrillation. They also found that increased fitness was inversely and independently associated with the decreased risk of developing atrial fibrillation, and the decrease in risk was most precipitous in those who went from least fit to moderately fit, as has been widely reported in the literature. Topic number 6, activities associated with an increased risk of cardiovascular events. When we talk about extreme exercise can be more than marathon running. I've been very, very interested for many years now in common recreational activities as well as domestic chores that may be associated with an increase in cardiovascular risk in the general population. In my line of work, you also get used to reading the obituary columns when you're dealing with high-risk patients. I remember vividly picking up the paper one day a few years ago and seeing this obituary column. Because I recognized this gentleman. I didn't know him well, but he was a local guy. And I'm thinking, what is he doing? I just met him a few months earlier, got to be in his early 50s. He looked as sound as could be in terms of health. And then as I read the obituary column, some things stuck out at me. Mr. Janke died of a heart attack Wednesday while playing racquetball at a local club. He was 55. Racquetball, squash, high-intensity, stop-and-go anaerobic types of activities are great. But for people at increased risk for cardiovascular disease, perhaps likely a trigger for acute coronary events. I did a Google search at the time and came up with this report, which really basically confirmed that this wasn't an exception. Sudden death and vigorous exercise, a study of 60 deaths associated with squash rackets by Northcote and colleagues. Another topic that interested me because I lost two dear friends, a chairman at the University of Michigan and a physician I worked with at Penn State years ago, to snow removal. And I remember picking up the paper in Detroit in the early 1990s and was mesmerized by this headline. At least 8 people died Wednesday in Detroit after snow-related exertion. In Wayne County alone, 17 heart attack deaths were attributed to exertion since the snow began Tuesday. Most of the victims were older men clearing their walks and driveways of snow. As a result, I became fascinated with this question. What are the cardiac demands of heavy snow shoveling? What's the incidence of acute myocardial infarction after major snowfalls in the Detroit area? First study we did was the parking lot at Beaumont Hospital, where we actually asked the grounds crew to spread out snow. They said, Dr. Franklin, we normally push them in big piles to the side. I said, no, I'd like to have about a 4-inch layer of heavy snow so we can do some research studies. We actually monitored oxygen consumption, heart rate, blood pressure, and at the same time of day, on a different day, we did a peak or maximal stress test. We told these guys, shovel heavy, wet snow at a comfortable pace, your own pace, for 10 minutes. Here you see a comparison of the hemodynamic and oxygen uptake responses. Basically, same heart rate as maximal exercise testing during snow shoveling, higher rate pressure product, key index of myocardial oxygen demand, yet oxygen consumption during snow shoveling was only about 60% of that during treadmill testing, and rating of perceived exertion slightly lower during snow shoveling. What you see is a disproportionate myocardial to body oxygen demand, and we concluded this study by saying high rates of myocardial oxygen demand clearing heavy wet snow could lead to cardiovascular complications. Second study we did, we had 12 days of blizzard conditions in the Detroit area, so I asked our fellows and residents to go check out the emergency center and see how many heart attacks came in over those 12 days. 20 heart attacks came in, 5 of those were involved in removing snow. Interestingly, all 5 were men, all 5 were habitually sedentary, all 5 ages ranged from 55 to 77 with a history of risk factors or acute coronary events or revascularization surgery. 4 of the 5 had BMIs over 30, so they were obese. Perhaps most astounding, 2 of the 5 had heart attacks when they were using an electric snow thrower. 4 of the 5 heart attacks occurred in the early morning hours when there's already a heightened risk, we know, due to circadian variation of acute myocardial infarction. So we concluded this study by saying habitually sedentary, middle-aged, and older patients at risk for heart disease, including those at risk for a variety of risk factors, should be cautioned regarding the risk of acute myocardial infarction following manual or even automated snow removal, especially during the early morning hours. Dr. Pertha Chowdhury came to me. He was a young fellow at the time, and he said, do you have any other studies? And I said, let's look at deaths that occur. So he went to the county coroner's offices after 2 heavy snowfalls and identified 271 people who had died around the times of 2 heavy snowfalls, and then went back through the death records meticulously going through and found that of those 271 in the Detroit area, 2 snowfalls, 36 were engaged in snow removal at the time. In fact, if you look at the week before the storm, exertion-related deaths, 2, the week of the storm, 24, and the week after the storm, 17, when people were still cleaning up. I oftentimes caution my cardiac patients and say no snow removal, and once in a while get an obstinate coronary patient who says, Doc, I've been doing this all my life. I'm going to continue to snow removal, continue to shovel snow. My answer is always the same. You don't have to listen to me. It's not a problem. Make sure you get a top-of-the-line snow shovel. He says, what do you mean by top-of-the-line snow shovel? I say one equipped with defibrillation pads, because your wife may need it to resuscitate you. When students say to me, why is this such a big problem? And actually patients oftentimes say to me, from a physiological perspective, what do you think's going on? My answer is as follows. I believe snow shoveling wreaks cardiac havoc because of 5 physiologic factors. Number one, arm exercise is less efficient than leg exercise, so at a given workload, the heart rate and blood pressure is much higher during arm work than during leg work. Secondly, very importantly, working in an upright posture, especially when the legs are frequently motionless, results in blood pooling in the lower extremities when myocardial demands may still be high. You got superimposed isometric static exertion, the Valsalva maneuver, and inhalation of an exposure to cold air, which causes coronary arterial vasoconstriction, raises blood pressure, and in fact can decrease coronary perfusion at a time when the demands are extremely high. This last study we did, at least where I live, people do deer hunting, and we get reports every year of deer hunters who go out and die while they're deer hunting. And we decided to do a study in which we looked at Holter monitors of 25 deer hunters, 17 of whom had known coronary disease. We actually did stress testing on each of these deer hunters as well. Our conclusion is as follows. Deer hunting can evoke sustained heart rates, ischemic ST depression, and threatening ventricular arrhythmias in excess of those documented during maximal treadmill testing. The strenuous nature of deer hunting, coupled with presumed hyperadrenergia and superimposed environmental stresses, may contribute to the excessive cardiac demands associated with this activity. This will blow your mind. Here's an ECG of one deer hunter who never moved. He was standing next to a tree. But as he was standing next to a tree and he saw 100 yards in front of him a deer, and his heart rate went from about 65 up here. At this point, that artifact is when he was actually pulling the trigger, and as he saw the deer drop, that was his heart rate, still not even moving. New way of stress testing. Show deer hunters a picture of a deer. In 2 minutes, you can get their heart rate up to maximum levels. We basically showed here that when we compare the heart rates during deer hunting, sighting, aiming, and shooting a deer, got this guy's heart rate up to the same level we were able to achieve on maximal exercise testing, and dragging the deer much higher levels. It's not surprising then, with such high cardiac demands, cold weather, eating, smoking, drinking, that we see lots of acute coronary events during deer hunting season. Topic number 7, pre-participation screening, prophylactic interventions, establishing a cardiovascular performance clinic. Deb Reby did a great job in putting together a group to re-examine ACSM's recommendations for exercise pre-participation health screening. And basically, if you said to me, Barry, what were the major differences versus previous years? I'd say, number one, the major differences in the new screening guidelines was that we looked at, number one, the current level of physical activity, any known signs or symptoms that they typically got at rest or during exercise, and the presence of known cardiovascular, metabolic, or renal disease, and lastly, the desired exercise intensity. Did they want to start with high intensity? Did they want to start with moderate intensity exercise? We eliminated reference to age cutoffs and risk factor profiling. We eliminated the terminology low, moderate, or high risk classifications. We no longer use the term medical exam or exercise testing, because the more we thought, why should ACSM be telling a given doctor, you need to do an exercise test on this particular patient? That should be the primary care physician's decision whether he or she wants to do an exercise test, or for that matter, what type of medical exam. So we simply use the verbiage medical clearance. We also came to the sobering realization that people with asthma or emphysema aren't necessarily at higher risk for acute coronary events, so we no longer included them in our medical algorithm. Here we developed a rather complicated algorithm which has gone into the new guidelines, as well as this paper in Medicine and Science and Sport, where number one, we look at the participation in regular exercise, yes or no. Number two, we define the medical history with specific reference to cardiovascular disease, renal or metabolic disease, and adverse signs or symptoms. And three, the desired exercise intensity and whether medical clearance was in fact recommended. When people say to me, what are some key prophylactic interventions we can use to prevent acute coronary events, I oftentimes highlight this paper by a friend and colleague at Harvard, Dr. Murray Middleman, who actually published this in Circulation 2011. I think it's very telling. Basically, what he shows in this is that as we compare the active individual versus the sedentary MI risk, the active individual over 24 hours is at lower risk than is the sedentary individual. Some studies say as much as 50% lower risk. Point number 2 in this diagram. When that active individual goes out and does vigorous physical activity, yes, his or her risk does increase, but increases only to the extent that it's about the same as the sedentary person at rest. Who's at greatest risk? It's the sedentary individual who goes out once a year or once every decade and decide he's going to play racquetball or he's going to shovel heavy, wet snow. His or her relative risk may increase more than 100-fold. And as a result of these kinds of studies, in the new ACSM guidelines and in this pre-participation screening paper, we strongly advise when previously sedentary adults initiate an exercise program, level walking should be strongly recommended. That is 2 to 3 miles an hour, 2 to 3 METs, gradually increasing the intensity to 3 to 5 METs over 2 to 3 months, provided that the individual remains symptom-free. We believe this strategy will reduce injury, increase fitness without going through a period during which each bout of vigorous exercise associated with large spikes in relative risk. We refer to this as the progressive transitional phase, and it was highly emphasized in Reeby's report and the latest issue of the guidelines. Very, very important. We need to do a better job here, and I learned a great deal from Dr. Paul Thompson when he came out with the initial report suggesting that simply out of all the things that we look at, making the patient aware or the client aware of symptoms is probably one of the most significant things we can do. He said, neither superior athletic ability, habitual physical activity, nor the absence of cardiac risk factors guarantees protection against an exercise death. Forewarning symptoms appear to present the only clue to impending cardiovascular events. I tell people, as does Paul, if you're exercising and you get pain or discomfort from your belly button on up, it comes on during exercise, it goes away when you're resting, it could be an anginal equivalent. Dr. R. James Barnard published this landmark paper in Circulation, 1973. Took healthy individuals who had normal maximal exercise tests, and then on a different day, took them to the lab, put the speed and grade up, had them suddenly start exercising vigorously. And in this individual who had a maximal exercise ECG, that same individual, when subjected to sudden, strenuous, high-intensity exertion, 2/3 of the population showed ischemic ST segment depression. When he had them jog in place prior to that vigorous exercise, the ST depression was literally obviated or eliminated. So it highlighted to me a very, very important principle that I've told patients for years. Don't walk in the gym, turn on the treadmill at 7 miles an hour and suddenly start jogging. Those are the people who die suddenly in the gym each year. And AEDs, no question about it. They're virtually, it's absolutely essential. The point I made earlier is I don't care whether you're fit or unfit. While you're out jogging, your relative risk goes up. If you're habitually sedentary, it may go up 100-fold. If you're regularly active, it may go up 2 or 3-fold. But needless to say, you need an AED in virtually every exercise facility because we can save lives. As a result of all these things, what we did is decided right after the 3 deaths in Detroit in 2009, open up a cardiovascular performance clinic. We're using the same staff. We didn't have to buy any additional equipment. We had several docs who were very, very interested in this. But I said to our hospital administration, you can't charge $2,000 for an echo and a stress test because nobody will come. Long story short, what we did is we developed an algorithm. And Dr. Aaron Bagish, I don't know if he's here today, but was very, very helpful to us in putting this together. He's got a very highly successful program in Boston, at Mass General and Harvard, where he does this. We've been doing it in Detroit for the last several years, and it's been an overwhelming success. People can refer themselves. All undergo the following: history and physical exam by one of our cardiologists, 12-lead ECG, echocardiogram, cardiopulmonary stress test. Cost is about $370 is what we charge. If they're over the age of 40 or multiple risk factors, we recommend a coronary calcium score. So we've used this, and we've had several hundred, probably close to 1,000 people now go through the Cardiovascular Performance Clinic. The hospital likes it because we're getting new business, incremental business. They also like it because they're not waiting 3 months or 6 months for a check from Medicare or Blue Cross. People walk in, the runners say, here's my check, take me through it. We try to do this in about 2 hours and 15 minutes. Here's what it looks like. You come in, you have an echocardiogram. If the echocardiogram is unremarkable, we do a cardiopulmonary exercise stress test. Then I sit down and review the metabolic data, including VE, VCO2, respiratory exchange ratio, VO2, and then they sit down with a clinical cardiologist who reviews the echocardiogram and the ECG findings. Topic number 8, case studies and medical marvels. See some very famous people in these slides. Right here, Derek Turnbull. Derek Turnbull, a longtime marathon runner. He was known for running marathons in his early 70s, about the same times as he did in his 20s and 30s. He was once asked, what's the secret to your training regimen? And he said, I'm a sheep herder in New Zealand, so I'm doing heavy physical labor. Unfortunately, Derek Turnbull had a stroke at the age of about 68. 5 years later, he died in his sleep, probably of some type of cardiovascular condition in his early 70s. What you see here is a guy by the name of Frank Shearer, first on skis, water skis at the age of 39. Here's Frank Shearer at the age of 100 on water skis, featured a few years ago in National Geographic. Charles Loper, pumping iron, Newport Ritchie Fitness Center, and of course, Clara Barton. I want to share with you, as I finish this section, 3 very, very famous case reports, case studies. The guy you see before you, his name is Ed Whitlock. Ed lives in Canada. He's currently 86 years of age. At 85, in that picture, he ran a marathon under 4 hours. Second case that got my attention was published just a few months ago. Herbert Fred, who is internal medicine faculty at McGovern Medical School, Houston, Texas. I remember reading about this, and I found it fascinating because he's listed in the Guinness World Book of Records. But he opened his case report with the following. From the moment we are born, he said, each of us begins a journey to the grave. Aiming primarily to thwart the onset and progression of cardiovascular disease at 37 years of age, I quit smoking, gave up alcohol, adopted a low-fat, low-salt, low-sugar diet, gradually reduced my meals to 1 a day, and chose running as my regular exercise. For the next 50 years, I steadfastly adhered to that regimen. Here you see, in 2016, he hit 250,000 miles. He also emphasized that during his training regimens, he was hit by a car once or twice, decided to go into indoor training, treadmill running, emphasized 2 times during treadmill running when there was power outage and he was running, but the treadmill was stopped automatically. Catastrophic events, and finally decided to retire from running at about 87 years of age. But the one that was most remarkable that got my attention was published literally a few weeks ago in the New York Times. Lessons from a 105-year-old French cyclist, Robert Marchand, is fitter than most 50-year-olds. He's over 10 Mets. Marchand decided, and this was a case report that was done on him in the Journal of Applied Physiology just a few months ago, decided at the age of 101 he wanted to further beat his world cycling training record for a person over the age of 100. He embarked on a vigorous regimen from 101 to 103. You can see his VO2 max went up substantially, his peak power output, his maximum pedaling frequency, and he set a new world record at the age of 103, covering almost 17 miles in 1 hour by bike. To conclude, I think it's important to recognize that high volume, high intensity training is not for everybody and may be associated with acute cardiovascular events. Doug Seals highlighted the fact that arterial dysfunction, characterized by large elastic arterial stiffening and endothelial function, results in age-associated cardiovascular disease. His work in this landmark paper shows unequivocally that exercise inhibits large artery stiffening with aging, optimizes arterial compliance, and improves endothelial function. He concluded this paper by saying exercise should be a first-line strategy for prevention and treatment of arterial aging and to combat the projected increase in population cardiovascular burden. More recently in this report, Bella, Ben Levine, and others examined the impact of long-term exercise in healthy seniors, 102 healthy seniors, using right heart catheterization, echocardiographic studies to define left ventricular pressure volume relationships and the Frank-Starling curves. Basically, what they did is look at 4 groups: sedentary, casual exercisers, committed exercisers, and competitive master athletes. In the conclusion, low dose of casual lifelong exercise do not prevent the decreased compliance and distensibility observed with healthy sedentary aging. In contrast, those categorized as committed exercisers or master-type athletes throughout adulthood prevented most of these age-related changes. These were very, very provocative physiologic and clinical data. I think to summarize at best, Ben Levine in this point-counterpoint summarized 6 points, which I certainly agree with, and he said them better than myself. Athletes have large compliant hearts that generate large stroke volume. The heart of the senior athlete is youthfully compliant and in some cases 30 years younger than their chronological age. Dr. Levine emphasized that extraordinary endurance exercise may cause fatigue of cardiac muscle, most notably more prominent on the right side than the left ventricle, but does not appear to stimulate pathologic biological processes. He went on to say that the older athlete is probably at risk for increased atrial fibrillation, though lower doses of physical activity do not appear to increase this risk. Number 5, evidence that years of intense training accelerate atherosclerosis is limited, and he contends, and I agree, are likely countered by the benefits of training on cardiovascular and vascular structure and function, but lastly admitted that high intensity, especially high intensity interval training in the presence of advanced atherosclerosis likely does increase the risk of acute cardiovascular events, especially if ischemia is present and exercise training does not prevent the atherosclerotic process. This paper got my attention, and basically those circles emphasized everything that I just suggested, or that Levine just suggested, but they added something else. And Dr. Mike Joyner from the Mayo Clinic was on this paper. And what I was really impressed with is this section right here. When patients say, I want to get involved in strenuous endurance exercise, who do we say no? Who should there be cautions? And who should we say go for it? Here they emphasize that people with pretty severe atherosclerotic heart disease, myocarditis, Marfan syndrome, channelopathies, inherited cardiomyopathies probably should avoid the strenuous exercise. Secondly, history of important cardiac symptoms, implanted cardioverter defibrillator or pacemaker, clinically overt or potentially life-threatening arrhythmias. Here we got to really be cautious about strenuous exercise, but certainly patients who have no signs or symptoms of cardiovascular exercise during cardiovascular exercise, those people should be encouraged because of the benefits that it can provide. I think the best summary of my talk, however, was in this second last slide, which I'd like to highlight for you. Paul Thompson was on this. They really summarized the literature beautifully. Eisvogel's. The possibility that too much exercise training could produce myocardial fibrosis, coronary calcification, or atrial fib is interesting and indeed worthy of further investigation. However, even for very active, lifelong endurance athletes, the benefits of exercise training outweigh the risks. There may be also, very interesting and very true, small subsets of the population with genetic predispositions to cardiovascular disease for whom vigorous exercise may in fact be deleterious. But they concluded this paper in JACC published last year by saying the issue, however, for most developed countries is not concern about too much exercise, but rather the absence of any exercise among most of the population. As I conclude this talk, I think Sir Isaac Newton summed it up best when he said, "If I can see further, it is by standing on the shoulders of the giants." This presentation was made possible in large part by the extraordinary research contributions of many past and present esteemed ACSM colleagues and friends, as listed below, and several of whom are pictured below. To them and to you for attending today, I express my sincerest thanks and appreciation. Thank you very much.
I'm sure that we all agree that the spirit of D.B. Dill was captured today, and if D.B. Dill were here physically, he would be very proud of this lecture. Thank you so much for all that you've done in this research area. We wish you continued success, and as a token of appreciation from the American College, please accept this plaque.
Thank you.
Yes.
Thank you, sir.
2 quick announcements.